my talk's going to be a little broader than melanocytic lesions. And as an oncologist, there's no question I've seen very recent dramatic advances in how we approach metastatic non-lymphoid cutaneous malignancies, several different types. And what I'm going to focus on is advances in melanoma, and then in basal cell carcinoma, and then in Merkel cell carcinoma. Everyone here knows that stage 4 melanoma is horrible, prognosis is terrible, and while there are no good metastatic melanomas in the AJCC staging system, we still subdivide stage 4 melanoma prognostically. Stage 4 M1A is mets to the distant skin or soft subcutaneous tissue, or lymph nodes, B to the lung, C to other parts of the body. And if one looks at the large database that led to the most current AJCC staging system from 2009, one can see relative differences in long-term survival, but overall, the vast majority of patients are succumbing to the melanoma. Also, LDH is an important prognostic marker for survival also, such that in the staging system, anyone who has elevation of LDH, irrespective of the location of the metastases, is classified as the worst substage of stage 4 disease. And therapy historically has not been good. Until 2011, we had only 2 treatments FDA approved for the management of stage 4 melanoma. In 1975, dacarbazine chemotherapy, an alkylating agent administered by vein. Depending on what study one looks at, the response rate ranges anywhere from 5% to 20% of patients, and benefits are largely partial and non-durable and do not translate into a survival benefit. We have looked at combining chemotherapies together, adding to dacarbazine, and we see increases in response rate, but also toxicity, and still no relative survival benefits to doing so. In 1998, the first immunotherapy, a cytokine, high-dose interleukin-2, was FDA approved, with efficacy in a small subset of patients. But we needed to learn more about melanoma, and over time we did, both in the arena of targeted therapy and immunotherapy, and that's what I want to focus on. In terms of targeted therapy, I don't need to belabor the MAP kinase pathway as people are very familiar with it from prior slides, but I do want to highlight that while you have NRAS mutations in approximately 20% of melanomas and BRAF in approximately 50% that activate MEK and then ERK and downstream, leading to proliferation, there are other RAF proteins, such as CRAF. And that becomes important when one considers targeting BRAF and potentially allowing for escape through CRAF. So this slide just highlights that intermittent sun-exposed skin has the highest incidence, relative incidence of BRAF mutations, but they are present in mucosal, acral, and chronic sun-damaged skin, and then there are other mutations, as we know, such as KIT mutations present, but much less so, less than 1% in the intermittent sun-exposed skin. So preclinical models had shown that mutant BRAF, the V600E mutation, and other V600 mutations, is clinically important, and that if you target preclinically the mutant BRAF, you could lead to death and inhibit proliferation of melanomas. And so that led to clinical investigation. And the first 2 agents, both oral inhibitors of BRAF, were vemurafenib, and in this study, in the phase 3 study, patients with stage 4 melanoma who had a V600E mutation, first-line therapy, were randomized to vemurafenib alone or to the FDA-approved chemotherapy, dacarbazine, with co-primary endpoints of progression-free survival and overall survival. The other BRAF inhibitor being studied was dabrafenib, also an oral agent administered twice a day in patients with V600 mutant BRAF, so not just E, K also, and primary endpoint of progression-free survival, and randomized against dacarbazine. Just to highlight the characteristics of the patients, 2/3 of them had the worst substage of stage 4 disease, M1C, 66%. A third had elevated LDH, and this study allowed for crossover. When we look at the results of these studies, in the BRIMS 3 study with vemurafenib compared to DTIC, one sees a very striking improvement in response rate. The response rate to vemurafenib was 48% versus 5.5% with chemotherapy. And that translated into statistically significant improvement in median progression-free survival from 1.6 months to 6.9 months. So a nice improvement, but still suboptimal. And median overall survival also increased in a statistically significant manner from 9.7 months to 13.6 months. So a nice improvement, but again, suboptimal. Here's data from the phase 1 study with vemurafenib, just to highlight how quickly these type of targeted therapies could work. Here's a baseline PET scan, and one could see on a repeat PET scan 15 days later, already significant decrease in metabolic activity of the tumors. And here is the progression-free survival curve showing the benefits in terms of progression-free survival. And with longer follow-up, we'll learn more about the tail ends of the survival curves. The BREAK-3 study with dabrafenib also showed an increase in response rate. Again, dacarbazine, as I mentioned earlier, in studies ranged from 5 to 20% response rates. Here was 19% response rate to dabrafenib, still much higher, 53%, and increase in progression-free survival up to 5.1 months. If one compares, and that was statistically significant with a hazard ratio of 0.3. If one compares the two BRAF inhibitors from their respective phase 3 studies, one sees response rates in both studies of approximately 50%, so much better than what the expectation was of standard of care at that time of dacarbazine, and median progression-free survivals of between 5 to 7 months, which is much longer than the less than 2 months one would expect to see with dacarbazine. But that's not optimal. We need to do better. So what about inhibiting downstream in the pathway at the level of MEK? Remember, there are other RAF proteins. RAS could activate CRAF that could activate MEK. So MEK could block all of that signaling. So the METRIC study was performed, the phase 3 study with an oral inhibitor of MEK called trametinib, and randomized against dacarbazine or another chemotherapy called paclitaxel, was a primary endpoint of progression-free survival in patients who had mutated BRAF and a good performance status and no prior BRAF or MEK inhibitor therapy, and at most had one prior systemic therapy. And the results, there was an increase in response rate from 8% to 22%. Median progression-free survival increased from 1.5 to 4.8 months, and overall survival from 67%, 6 months overall survival, to 81%, statistically significant. But the hypothesis that blocking MEK downstream would work better, at least with this agent, didn't pan out. If one compares the results from the 3 studies, one sees that actually with this specific MEK inhibitor, we didn't do any better in terms of median progression-free survival, and response rate didn't approach what we were seeing in studies with the BRAF inhibitors. So what about blocking both? Block BRAF and MEK at the same time, and there's strong rationale from that from preclinical models in terms of synergy, in terms of potentially delaying the time to development of resistance, and also in decreasing the incidence of cutaneous toxicities. Vemurafenib, for example, could cause in approximately 20 to 25% of patients squamous cell carcinomas. Preclinical models demonstrated that the development of squamous cell carcinomas would be significantly decreased in the setting of adding a MEK inhibitor. And so, from initial study, patients were randomized to dabrafenib alone, the BRAF inhibitor, with no trametinib, the MEK inhibitor, or to the dabrafenib with 1 milligram of trametinib or 2 milligrams. This arm is the full monotherapy dosing of both agents, and that's well tolerated. And one saw in this study median progression-free survival, again, was the BRAF inhibitor, 5.8 months, consistent to what we saw in the phase 3 study, increased to approximately a little more than 9 months when you have the combination. 1 year progression-free survival, also proportional increases, and response rates went from the 50s to the approximately a little more than 70%, and also median duration of response also from 5.6 months to 9.5 and 10.5 months with combinations. And overall survival increased from 68, 70% to 79%, despite 80% crossover. And the incidence of cutaneous squamous cell carcinoma decreased. And we do see more fever with the combination compared to BRAF alone. So if one looks at this, these studies, one sees when you look at Vemurafenib, and this is phase 2 and phase 3 data, when you look at the BRAF inhibitors alone, you see pretty consistently response rates 50 to 60%, median progression-free survival is 5 to 7 months. With the MEK inhibitor, the response rates are lower. In this one study where patients already had a BRAF inhibitor and then sequentially were treated with the MEK inhibitor, response rate was 0%, median progression-free survival 1.8 months. And when you now have the combination of BRAF plus MEK inhibition, you get response rates into the 70% and median progression-free survivals of approximately 10 months. And this led to phase 3 investigation of BRAF inhibition alone versus BRAF plus MEK concomitant inhibition. So 2 studies. One is Vemurafenib plus cobimetinib, that's a MEK inhibitor, versus the BRAF inhibitor alone. And response rate, there was statistically significant improvements in response rate and median progression-free survival, 6.2 months to 9.9 months, 45% to 68%, all consistent with the data we saw in previous studies. And there was also an improvement in 9 months overall survival from 73% to 81%, and follow-up on the study is ongoing. In the second study, BRAF inhibitor alone was compared to BRAF inhibitor plus the MEK inhibitor. Response rate improved from 51% to 64%, median progression-free survival from 73% to 7.3 months to 11.4 months, and 12 months overall survival also had a statistically significant improvement from 65% to 72% of patients, much better than what we did in the era of dacarbazine. And we've seen clear benefits by combining BRAF and MEK inhibitors, such that if one doesn't have, from a clinical practice standpoint, if one is using a targeted therapy in patients that have a V600 BRAF mutation, the standard would be to use the combination therapy unless one had a comorbidity that would prevent one from using a combination therapy. So MAP kinase targeted therapy has a very high response rate, but there are limitations to durability. While we see incremental improvements, the combination of BRAF plus MEK inhibition leading to progression-free survival medians of approximately 10 months, that's good relative to where we started, but that's not what our patients are hoping for. And also, 50% of patients approximately have BRAF mutations. These treatments work in patients with BRAF mutation. So it is not an option for patients who do not have mutated BRAF. But this led to multiple FDA approvals. Vemurafenib was FDA approved as a single agent in 2011, dabrafenib in 2013. Trametinib, even though it did worse, just when one could look study to study, it was FDA approved as a single agent, and then the combination in 2014 of dabrafenib and trametinib were FDA approved. So because only 50% of patients have targeted therapies, and while we have benefits with the BRAF targeted therapies, they're still not creating the durable benefit we want in enough patients. We need to look at other approaches, and immunotherapy is a very important approach. And there are many lines of evidence demonstrating over time that the immune system is important in modulating melanoma, the presence of tumor-infiltrating lymphocytes, the evidence of regression of primary lesions, and activity of cytokines, interferon alpha in deep stage 2 melanomas or in stage 3 melanomas, and the efficacy of high-dose interleukin-2 in stage 4 melanoma, where 16% of patients will have a response. And while it's a very toxic therapy causing potential for capillary leak syndrome and renal failure, and one may need ICU-level care, the reason it was FDA approved is that 5 out of 100 people could develop durable benefit, which is complete and long-standing. So as we learned more about the immune system, we learned that there are a lot of regulatory networks that modulate the activity of the immune system, normal mechanisms. And I want to discuss two of them. One is CTLA-4 and the other is PD-1. CTLA-4, basically when an antigen-presenting cell or a dendritic cell expresses antigen in the context of MHC molecule, it's recognized by the T cell receptor, but to activate the T cell, there needs to be multiple other co-stimulatory interactions, including CD28 with B7 on the dendritic cell. When the immune system needs to suppress itself, CTLA-4 is expressed on the T cell. It has higher affinity for B7 than CD28, so it'll disrupt this interaction, leading to deactivation. Ipilimumab is an antibody, that monoclonal antibody that binds to CTLA-4 and prevents this interaction, allowing for maintenance of this interaction and maintaining activity of the T cell. PD-1, when a tumor cell develops and evolves, it needs to find strategies to stay alive and to survive, and it does that through many of the mutations and chromosomal changes that were discussed earlier today. But the tumor also has to find a way to avoid our immune system, a natural response to keep things away that shouldn't be there. And one mechanism that the immune system uses or selects for to do that is by expressing on its surface a protein called PD-L1. And when an immune cell, such as a T cell, comes into the tumor, it expresses PD-1. When PD-1 sees the PD-L1 on the tumor, it is an inhibitory interaction for the T cell, and the T cell is inactivated right in the area of the tumor, exactly what we don't want. And many melanomas have expression of PD-L1 as and allowing for this potential downregulation of T cell activity in the tumor microenvironment. And we're seeing this now in many different cancer types. So what about blocking either CTLA-4 or PD-1? So first, CTLA-4. So a monoclonal antibody called ipilimumab was developed and studied. And I'm going to show the data, and this is the data from the registrational study that led to FDA approval of ipilimumab in 2011 for patients with stage 4 melanoma who already had a prior therapy, and they were randomized to ipilimumab alone or to a peptide called GP100, which not felt to be very efficacious, or to the combination to see if, while ipilimumab takes the brakes off the immune system in a more general way, maybe using a melanoma protein, we could drive that more towards an anti-melanoma response. And bottom line is, we did not see a relative benefit of adding GP100 to ipilimumab versus ipilimumab alone, but we do see a significant benefit of using ipilimumab over GP100. There was while response rates are low, 10% or less, if one looks at longer-term survival, 2-year survival, with the GP100, it's approximately 14% of patients. With ipilimumab, 24% of patients. So extra 10% of patients having 2-year survival. And after 3 years, that survival curve really starts to flatten out, and we now have data 10 years out of patients doing well after ipilimumab treatment. And ipilimumab is administered by vein, IV, once every 3 weeks for a total of 4 treatments. And patients that had good benefit, but then eventually had progression or recurrence, they were allowed to be reinduced with 4 treatments, and sometimes they would have even a better outcome after a reinduction. In terms of PD-1 targeted therapy, there are 2 antibodies, pembrolizumab and nivolumab, and these were both FDA approved just in late 2014 based on large phase 1 studies, both showing significant efficacy. Response rate to pembrolizumab 26%, nivolumab 41%, and also the very good durability to response if one gets a response. And in these studies, patients potentially had multiple prior therapies. And subsequent investigation looked compared to other agents. So the PD-1 inhibitor nivolumab versus dacarbazine chemotherapy. And we saw improved survival with nivolumab. These are patients who did not have a BRAF mutation, first-line therapy, primary endpoint of overall survival, and there was placebo control. And again, almost 2/3 of the patients had the worst substage of stage 4 disease, so not good patients. And we see response rate, DTIC 14%, 40% was the PD-1 inhibitor. Median progression-free survival, 2.2 months to 5.1 months. And 1-year overall survival, 42%. So more than half the patients didn't survive if you were using a chemo-based approach. 73% of patients alive in 1 year, and less toxicity, less high-grade toxicity, 18% to 12%, all statistically significant. So what about you? How do you choose, PD-1 inhibitor or ipilimumab? And so one study was performed over 800 patients. Patients were randomized to pembrolizumab either every 2 weeks or every 3 weeks, or ipilimumab, the standard 4 dosing. These are not just for 4 doses, PD-1 inhibitors. And one saw statistically significant improvements in 6 months progression-free survival, 12 months overall survival, and response rate if you used pembrolizumab, PD-1 inhibition, versus as opposed to ipilimumab for patients who have not had prior CTLA-4 or anti-PD-1 based therapy. And if one looks at the numbers, one sees response rates go with ipilimumab around 12%, up into the 30s, 12 months overall survival from 58%, which is an incremental improvement over dacarbazine, up to 68, 74% of patients, and less toxicity than ipilimumab. The toxicities are autoimmune, rash, colitis, hepatitis, nephritis, endocrine-based uveitis, etc. And so in terms of high-grade toxicity, 20% was ipi, and approximately 12% was pembrolizumab. As I mentioned, from the phase 1 data, pembrolizumab and nivolumab were FDA approved. Pembrolizumab was both were FDA approved for patients, because it was based on the phase 1 data, for patients who've already received ipilimumab, and if you had a BRAF mutation, you have had received a BRAF inhibitor, not as first-line therapy. And the dose of pembrolizumab FDA approved is 2 milligrams per kilogram every 3 weeks. This study uses 2 weeks and 3 weeks. The dosing is higher than the FDA-approved dose. So immune checkpoint modulation has the potential for durable benefit, and response rates are higher with PD-1 targeted therapies. And also, just because of the way we capture responses by looking at change in size, that underestimates response and benefit, because people could have inflammation of tumor from treatment. So on your scans, they can actually get bigger before they get smaller. And so more specialized immune response criteria have been developed to provide probably better ways of assessing efficacy. And then finally, in terms of immunotherapy, what about combining ipilimumab and nivolumab? And there are, as discussed earlier, rationales for such approaches. And a stage 4 study, 945 patients, no prior systemic therapy for advanced disease. And the data was recently reported for progression-free survival. Overall survival data is not reported yet. And one sees with ipilimumab alone, 2.9 months median progression-free survival, 6.9 months with nivolumab alone, 11.5 months with both. The PD-1-based arms had statistical significance over ipilimumab, so that met the primary endpoint. You pay a price in terms of high-grade autoimmune toxicities, 55%, versus 27% was ipi alone in the study, and 16% was nivolumab. From studies also, if one looks at response rate for the combination, that approaches 60% of patients also. Can we try to decide which patients we may want to avoid the toxicity of having to add ipi to PD-1 targeted therapy and say you could get PD-1 targeted therapy alone? So one potential biomarker is the expression of PD-L1 on the tumor. And if one looks at PD-L1 positive versus PD-L1 negative, the patients who had, in the PD-L1 positive patients, tumor, similar median progression-free survivals if you got PD-1 alone versus the combination, and both much better than ipi alone. But in the PD-L1 negative, defined as less than 5%, there was a clear better outcome if you used the combination versus alone. So that suggests that this may be a potential biomarker for who to say we should take the added toxicity risk and use a combination. This combination is not yet FDA approved for management of melanoma. So benefits and pros are targeted therapy has high response rate, limited durability, although there is a tail end of the survival curve. Immunotherapy, the durability is very key. And while response rate historically has not been as great with immunotherapy, when you start adding ipilimumab and nivolumab together, you're getting response rates similar to BRAF plus MEK inhibition alone, and these work also in the wild-type BRAF patients. So now we have many options for how to treat melanoma, much better than dacarbazine and therapies that have survival benefits. And so if one just looks at the NCCN guidelines, the last update in March, one could see that we have many options. Dacarbazine is not even listed in the options. And you use features such as how clinically stable a patient is. Do we need to optimize rapid response, in which case if they have a mutation of BRAF, we may want to use a BRAF inhibitor. And then we still are learning how to best sequence these therapies. So there's been dramatic advances. We need to learn how to optimally sequence and combine therapies. We need good biomarkers for efficacy and toxicity. We have to learn more about resistance mechanisms, but ultimately have to develop strategies to prevent melanoma from developing and to develop better adjuvant therapies for high-risk stage 2 and 3 patients. And then very briefly, basal cell carcinomas, often are treated curatively with excision, and there is sensitivity to radiation. But at times, patients can have bad basal cell carcinomas. One of my patients, she never went to doctor. She ultimately presented with a hemoglobin of 5.5, with this very large lesion. And we know that the vast majority of basal cell carcinomas have mutations that activate the Hedgehog signaling pathway, either by loss of function, either by activation of smoothened or inactivation of patch. Patch normally inhibits smoothen, that leads to activation of the pathway. So what about blocking Hedgehog inhibitors? This is a study that I was an investigator on, where vismodegib was an oral agent, was treated as a single-arm study in patients with either locally advanced basal cell or metastatic basal cell, refractory to surgical approaches or non-amenable to radiation approaches. And basically, from the update in 12 months, and data was recently published in the JAD, we see nice response rates, 47.6% in locally advanced, 33% in metastatic, duration of response 7.6 months, 9.5 months, and good overall survival. And so this agent is FDA approved based on this single-arm study. More recently, and here you can see the clinical benefit rate in metastatic disease and in locally advanced disease. And more recently, a second Hedgehog inhibitor, sonidegib, was FDA approved. And there's with 2 different doses were studied, 200 milligrams, 800 milligrams. And response rate was 200 milligrams, 43%, and 15% in the metastatic setting. And this was also FDA approved. So this is a significant targeted advance for patients that have extensive locally advanced or metastatic disease. And here's just to highlight a patient of mine who came from Connecticut and also neglected the lesion and presented with this large mass from basal cell and was not inclined, did not want radiation or surgery and would have required significant grafting. We treated her with vismodegib for 1 year. She had this outcome. We did punch biopsies in these 3 areas, and they were all negative. This is 2013. It's now 2015. It looks the same. So never had surgery, never had radiation. That is a potential for this type of treatment. The price you pay is toxicity, muscle cramps, taste changes, weight loss, and decrease in appetite being some. And very finally, last 2 slides, everyone knows Merkel cell carcinoma is a rare but aggressive malignancy associated with a novel polyoma virus, association with immunosuppressed state, viral T antigen in approximately 80% of Merkel cells, intratumoral CD8 positive lymphocytic infiltration is associated with improved survival. And we have an active chemotherapy regimen for stage 4 metastatic Merkel cell, platinum agents plus etoposide, extrapolating from the small cell lung cancer literature. But ultimately, when disease recurs or progresses, we don't have great next therapies. But given all these other points, what about immunotherapy? Merkel cell carcinomas also, many have PD-L1 expression. So I just want to mention 2 clinical trials we were part of here and treating patients on, and data is not public yet. One is a phase 2 study of MK3475. That's pembrolizumab, the PD-1 inhibitor I discussed earlier in melanoma, in patients with advanced Merkel cell carcinoma, no prior chemotherapy. And again, targets PD-1. I have patients actively being treated here on this study. And phase 2 study of a PD-L1 inhibitor. So instead of blocking the PD-1 part of the binding, you block PD-L1. And again, this is in patients that have received prior chemotherapy, platinum, etoposide, and we're waiting the results of the 2 studies. So significant advances in multiple different non-lymphoid cutaneous malignancies. Thank you.